Good afternoon to the esteemed panelists and the elegant audience gathered here. So, I'll be talking about a case, our tale of childhood headache, and the genetic aspects to it. So, I'll just go straight on the case. This was a 10-year-old girl who was initially admitted to another hospital, non-sanguinity, there was non-sanguinity, second order by birth. Then 3 months back, prior to the first admission, this child had a fever along with multiple episodes of vomiting. And then when the child was admitted to another hospital, from the day one, she had holocranial secondary headache. It was secondary, of course, there were so many other things associated. And then day 3, the child developed right-sided hemiparesis. And when the child was admitted at the end of week 1, there was some improvement, and gradually the child improved over a period of 15 days. This was the first admission. Then at that time, this was in February this year, there was a large infarct. The MRI was done. However, the angio and the MRV was normal at that time. Now this child, again, the first episode was there. This second time, the child was admitted again. So what happened? There was a headache, which was initially occipital, as told by the child to the mother, followed by holocranial. There was some change with posture, it increased, and vomiting caused transient relief of the headache. Then the child, along with this headache, had visual symptoms. She started seeing colored items, non-vivid visual items she used to see, followed by a dimness of vision, which was sudden after 3 to 4 days of the onset, because the mother could not say properly, and there was dimness of vision. Then there was seizures, for which the child was again brought to the hospital, then admitted. It was left focal motor seizures, and then the child was treated initially outside and at Basira hospital, and then the child was referred to us with a background of fever, vomiting, followed with headache, severe headache, seizures, and visual symptoms, followed by a dimness of vision. So at this point, a child, a 10-year-old girl, who begins with headache, followed by seizures, then dimness of vision. So I'd ask my esteemed panelists, any one of you, what will be your differentials?
Good morning, everybody. So, I'm Dr. Neha. A very interesting case. As you said, that there was a history of headaches, seizures, and recurrent paralysis, hemiparesis. I think the first thing which comes in mind, that too over a period of 3 months, the first thing which comes to mind is probably pediatric ADAM, because that is one thing which we are seeing very commonly these days. And obviously, we should be thinking of, not keeping the MRI or the CT in context, we can definitely think of pediatric ADAMs initially to start with, and obviously we'll have to rule out some thromboembolic conditions and cardiac conditions, and then coming to other conditions like pediatric moya, which can also have very similar presentation. I think I would also
Morning. As the child presented with fever and vomiting and some seizure, first for these episodes we can think about any infection, inflammation, or any post-infectious causes. For these episodes only, you can think about any viral infection, any bacterial infection, that is meningitis with some complications like vasculitis, like ischemic stroke. And if we think about the previous episodes also, we should think about the some inflammatory or demyelinating disorder, as Dr. Guna has already said earlier, edema or NMOSD or GARD, or some space occupying lesion may present with acute condition like that only, like any SOL or any abscess, and headache and visual symptoms may be due to increased ICP, and may be due to praise or some structural lesion. And in these age group, we can thought about as the disease is from last 3 months, we can thought about any metabolic syndrome also, like mitochondrial disorder or some acute metabolic crisis like UCD or organ disease. As the child is on 10 years of age,
Okay. So then with those differentials, because this was quite acute with a past history within 3 months with fever, the infection inflammation was in our mind initially. Then according to the mother, she used to have on and off headaches at least 8 times a month. And she being a child, there was no explanation of the headaches, like exactly how long, how it was relieved. She was saying that there was discomfort. Also, one particular history was that she would invariably have this after dance classes, and she used to love her dance classes, because in children we have to be aware that if they don't like studies, they may always say that we are having headache during studies. Also, few times it happened during a religious fast, and it was usually throbbing, holocranial, and sometimes associated with nausea, sometimes relieved somewhat after sleep. This was the brief history the mother could give, and she took paracetamol for reliefs. For the last 2 years approximately, she was having this kind of headaches. So, this in the background of headache, this child presenting twice with headache followed by hemiparesis with dimness of vision. Does it change? Does it add up to a differential in the background of headache? Sir, Arijit sir and Anshu sir, if you have anything to say.
Yeah, the first, what you mentioned about a past medical history, that's fitting into a classical history of migraine, photophobia, recurrence, uh, uh, exacerbated with exercise, dance. But then when you have the other things added on, you have to think about secondary headaches and causes of that. And as my colleagues have mentioned, para-infectious diseases, demyelination, ADEM would be a differential diagnosis, but we also have to think about other causes like vasculitis, metabolic syndrome that is presenting recurrently, maybe even a mitochondrial disease. And of course, we have to also keep other things like hematological conditions that could, prothrombotic stage that could give rise to these recurrent episodes.
Yes. Yes. The acute recurrent hemiplegia and holocranial headache and the characteristic features of migraine-like headache, we must consider all these differential diagnoses. We also should think about the cardioembolic stroke in this patient. But one important thing is here that the patient has an aggravation of headache during fasting. It is very important. And we must rule out the metabolic causes also.
Yes. So migraine-like headaches for 2 years, then followed by headache, focal seizures, and visual symptoms. This was the child till now. So with this, when the child came, the child was very sick. Then we saw that the pressure was okay, because that might be fever, headache, dimness of vision. Without going into further investigations, PRACE was one of the DDs. The pressure was okay, the vitals were stable, meningeal signs were absent at that time because there was fever. We meticulously checked. Visual acuity, it was peer was absent. Then the other things that there were pyramidal signs, of course, there. So that said that the child was having some kind of secondary headache, secondary to probably inflammation or infection. Now the findings that we got, that in MRI brain there was a subacute infarct in the right temporoparietal occipital region. There was gyral enhancement, optic nerve sheath showed enhancement. MR angio, MRV was normal. The other things as we show is normal. So this was the imaging where we see the infarcts. I'm not going into detailed description, all of us can understand. And the perineural sheath showed enhancement. This was the detail. In the ADC there was no, it was not black, so it was not very acute. So you see the history was first 3 months, then like 2 weeks prior to the admission. This was the temporal course of this illness. And one thing is this, there was meningeal enhancement as well. But the angio and the venography was more or less normal. So this was a childhood onset disease with headache followed by stroke. Then there's the dimness of vision. Vessel imaging was normal. BP, there were no waveform, and there is recurrent stroke, not exactly following an exact territorial pattern. So now, as our esteemed panelists already said, we were considering, because this was very acute at that time also, with dimness of vision, anterior optic pathway dysfunction, aiding a prothrombotic state, Mitochondrial or metabolic disease, a very rare association of CNS vasculitis, though primary I do not think that we see at such less age, but secondary causes were yet to be ruled out. Then the second panel was sent, the investigations, where we ruled out the infections as well, because in our country infections is very important. We did all this, lactate came out to be positive. Then APLA panel, this anti-beta 2 glycoprotein IgM came out to be positive. Other markers were negative. Then there was low protein C and S activity. However, this was taken with a pinch of salt because this was an acute case. We are planning to repeat it later on. But the thing is that the lactate level was high. We did twice it was high. So the treatment was started empirically. Supportive care was obviously given. Mitochondrial cocktail was started. Then we had a dilemma. I like also opinion because of the child was having dimness of vision. There was some suggestion of anterior optic pathway dysfunction. We gave an IV methylprednisolone, and the child improved after that. After the third pulse, the child's vision improved and the child improved. So there was our query. We gave that almost empirical because almost literally to save the child. But was that logical? Was that justified? Giving this, because we are understanding this might be a mitochondrial stroke, mitochondrial headache followed by mitochondrial stroke. Is that at all justified, or we did something wrong? However, the child regained the vision, but that is not the question. So, any opinion?
Was VP done?
Yes, I showed. There were no waveforms. There was also optic nerve enhancement. Any opinion from the audience whether? Yes, sir.
If the area of injury which was shown, did it show diffusion restriction? Did you have diffusion?
No, sir. I showed that it was the history was also corroborating with the time. It was 2 to 3 weeks. Then the child was first admitted in DCR hospital. Then came to us.
So it did not follow vascular territory, isn't it?
No.
So here we have a child who has got optic nerve sheath enhancement. He has got a lesion. He is having these headaches with an edema-like picture.
Meningeal enhancement is also
Meningeal enhancement is also the optic nerve sheath enhancement. I'm not very sure, but did you test MOG antibody?
Yes, sir. Those were also done. Those were in fact done by DCR hospital only, where edema was suspected.
Yes.
When the child came, edema was suspected. Those are all were negative.
MOG were negative.
Everything was negative.
I think in view of the sudden acute deterioration of vision and overall demyelination being thought about in the differential with optic nerve enhancement, and it could be that the child also could have sort of optic neuritis like a picture. So I would have definitely gone ahead in that circumstances with the IV methylprednisolone. Maybe it would have been an empirical treatment to think about rather than, because you have to save the child's eyesight and it's worthwhile. If you don't have any contraindications, it's worth the treatment with IV methylprednisolone.
So in mitochondrial stroke or mitochondrial headache, it is usually not like, so that was our dilemma. However, the child's eyesight improved and we did not till now face any medical legal consequence as well. So, but the thing is that then the child's, later on, this mutation came out to be positive. Heteroplasmy levels were more than 2%. So, it is always pathogenic for this 3243 mutation, which is the most prevalent mutation, and the studies have shown that the normal population has got around 1.5% prevalence of this mutation. So there is a wide range of phenotype who may not manifest because the heteroplasmy level is less than 2%. So this was very interesting paper. I'd request all to go through this because many of us are carrying this because of the heteroplasmy levels. We are not manifesting. It may manifest in cases of if there are stressful conditions. So this was our case where apart from the clinical features that I mentioned, there was also another feature apart from the mitochondrial thing. At that time, the genetics came out later. So there was low protein CS, elevated APLAs. So this was this thing, and they may cause meningeal enhancement, as we know. Infection may cause, and initially it was thought to be primary CNS demyelination, which it was not. All the antibodies came out to be negative, and then the lesion was not limited to white matter only. So these were the DDs that were crossed out. Now the one was difficult before the genetics came out. Whether it was due to a prothrombotic state, the headaches in prothrombotic state in children may present as those kind of recurrent headaches, nagging headaches, migraine-like headaches, and also in mitochondrial disease, this headaches may be a harbinger of stroke in children as well as in adults. So how to differentiate when we do not have the genetics in hand? So any answer from the panelists or the audience, or anything that here you have to make a comment? My first.
So can we go back to this MR pictures, please? Yeah. So actually, what does it show? It shows that there has been, and which occipital area you are focusing on. Do you think that's a unilateral or bilateral?
Bilateral, but different times.
Yes. So that is one point which is very, very important to understand, that there are two lesions in the occipital area which is large, which is predominantly grey impinging on the white, and this is basically a two-time process. And also the patient history of
two different times.
Two different times. So in this, seeing this with a headache, with a seizure, and the patient coming with a recurrent focal deficit, I would first, obviously, as you have said, that I would first thought of a mitochondrial radiology, and Mila's would be the first differential because of visual manifestations, right? And in this case, I would have straight away gone and do a MRS and seen for the lactate peak.
We had done, sir. I have not shown in the picture. That was not very prominent somehow in our institute. So we were trying to.
So because mostly you will be rewarded by that, because you will be. The odd point here is the meningeal inflammation that you're showing, that enhancement. That is quite a bit. That is not a very minuscule amount, right? So I would therefore suggest that there might be an additional pathology lurking behind, something which is going on with that, and that probably would be responsible for the optic nerve enhancement, whatever you have seen, and that probably has responded to the
IV methylprednisolone. Yes, sir. Then we were still not sure about this IV methylprednisolone this infusion, but the patient somehow improved. So I'm not going into the diagnostic criteria because that is too theoretical, and the pathophysiology related to genetic abnormality. The Milas is known for having migraine-like headaches. The pathophysiology is similar. It's a cortical spreading of depression. And why? There are 5 pointers why Milas leads to migraine-like headaches. One is, of course, the mitochondrial dysfunction leading to defective OXPHOX. Then the cortical spreading depression, which is linked to the migraine-like aura, which was present to some extent in this patient. She was not being able to say it properly. There is microvascular dysfunction, the small vessel abnormalities leading to injury, edema. Probably the mitochondrial stroke may lead to enhancement due to this point also. Nitric oxide imbalance that leads to vascular headache triggers, and lactic acidosis that was in the acute form led to this kind of accumulation of lactate, worsening of sensorium, this kind of things happened. So there was one thing, the headache recurrent stroke is explained by Meena. Sir also told, my panelists also told, but the meningeal enhancement, can that be explained by MENAS? So we searched literature. So it was seen that it is uncommon feature. But in tRNA mediated mitochondrial disease, which this particular mutation is 3243 with the heteroplasmy of 73% mediated by tRNA with a particular mutation, is associated with this meningeal enhancement. So headache followed by stroke with meningeal enhancement can be a sign of tRNA mediated mitochondrial disease. So this treatment outcome is always arginine infusion that we started in this patient, which is now available. Previously aspirin was given from they thought it's stroke, as everyone could have stopped. So that was stopped. Later on, then IV pulse, because of that we were confused regarding that why this optic nerve enhancement. Then the mitochondrial DNA mutation came out to be positive. We had a very good discussion with our genetist who saw that this was not only a mitochondrial mutation, but a heteroplasmy of 73% with tRNA mutation. The entire spectrum caused every clinical finding and every radiological finding could be explained by that particular mutation with that particular amount of heteroplasmy. So we have a bunch of cases in pediatric population, but usually the headaches are succeeded by strokes usually or other things that we see in CADASIL, which is not usually seen in 10 years or younger children, Fabry, homocystinuria, even moya moya with this RNF 213 mutation. And I'm not going into the details because migraine in pediatrics or in young adults is a polygenic disease if genes may be considered. But monogenic disease, if it is like the other mutations and mitochondrial, they have specific features. So our point is to pick up those specific features when the child is still having headache in the headache segment before the child proceeds towards stroke, vision loss or other things. So it's very important. So there is a like MR associated differentiation when we can have this monogenic migraine headaches plus strokes where we see all these kind of mutations. So we have different kind of steno-occlusive vasculopathy in one group with prominent moya moya pattern and without moya moya pattern. This is a differentiation, and the other group is where we see the vessel disease with tortuosity and aneurysm. And we know that if there is dissection, we have to check the kidney always, be it a children, be it a young adult. So this is the entire spectrum of monogenic headaches in children who lead to strokes with this kind of imaging features. I'm not going into details, but just the important finding. This was CADASIL in a 10-year-old girl. Apart from this kind of white matter changes, we can see the temporal lobe hyperintensity. Then come to a call for A2 variant. Here, one important thing as pediatric neurologists, there is antenatal ventriculomegaly. If a child antenatal ventriculomegaly later on presents with headache, if we find such kind of MRI patterns, we have to think of call for A2 mediated headache. This again we have to be very careful because it will lead to stroke. This is Fabry. There are other features as well, but if we see this kind of corpus callosum abnormality, then we have to think that they may lead to stroke later. This child if presents with headache. Homocystinuria, again there are white matter changes. This is classic moya moya, and we all know moya moya until the second decade may present with headaches only as the features because of the chronic insufficiency. This is actor 2. Again, not going into details, but see the genu of the corpus callosum and the brainstem region. There are abnormalities, and these headaches may lead to a stroke later. So the thing is that mitochondrial headaches, because lack of time, not going into details, but there are types of headaches which we miss often because they will present with stroke later on. They have typical migraine-like headaches, and tax and cluster headaches can be seen in tRNA mutations. So there were beautiful papers who traced this origin and the evolution of mitochondrial headaches and showed that the mutation that this particular child had, there 58% presented with headaches before the origin of stroke. So the thing is that we treated the child is now being on mitochondrial cocktail and this arginine, responded beautifully to arginine. Other treatments can be used, but the point was, could we detect the headaches before there was stroke? Is there any point of getting this headache treated before the child proceeds to a stroke and visual loss or something like that? Now the commonest mitochondrial disease is growing old. Unfortunately, we all are having that kind of mitochondrial disease. But the point is that can we pick a pathological one before it becomes more and more pathologic or deadly? That will be the question. Now this child is with the treatment headache free. Now she is saying, Amar ar matha byatha hoy na in Bengali. But the unfortunate thing from yesterday, her mother called, she is again having headache. So is there any way out? So I'll ask my panelists just your experience in short, if you have, or any way to how to proceed, because we are at a loss.
Excellent presentation. One question is that some patients have hemiplegic, familial hemiplegic migraine present with acute confusional state. In case of mitochondrial headache, do you have found in some cases, apart from stroke manifestation, presenting with acute confusional state with headache?
So it is very difficult to say in this case, particular case, or whatever mitochondrial we saw. At least I think the pediatric neurologist will agree. In acute setup, they are in confusional state. They have altered sensorium. Then it is very difficult to differentiate whether this is due to stroke or not due to other things. So it's very difficult. And most of the genetic headaches, I think, sir, can say better is polygenic. not monogenic. But the monogenic pediatric headaches are always, mostly, according to literature, will lead to stroke or stroke-like associations. Sir?
So I think it's an excellent case, and I think that enlarges our view of seeing the pediatric headaches, and we should be careful in deciding that whether this is a primary headache or something secondary is lurking behind. Because the phenotype may look like migraine, as Arijit has said, and you have also said that. So I think I therefore tell everybody that you should have a low threshold for diagnosing secondary headache in children. You have to be very careful. Secondly, if the headache, there are certain features like first the migraine time slot for headache migraine for pediatric patients is less than what is in adult patients, right? And I have seen people who are having headaches of half an hour, 1 hour, although the duration is lowest duration is 2 hours. But I have seen patients 1 hour, 2 hours, pediatric patients with migrainous phenotype, and investigations have not revealed anything, so we keep it at migraine, although it is not fulfilling the criteria, right? So the second thing, that if it is a persistent posterior headache, right, in children, that should be a red flag. You should all investigate that patient. Third is that case, suppose if you have thought about a secondary headache and do a neuroimaging, and on neuroimaging you have found something, then you should go in for now with the availability of genetic testing. But before that, I think you should form a kind of some kind of differentials before just blindly going for, because then the yield will be very low, right? And the fourth thing is that we can all collaborate on this and find out from pediatric neurology, adult neurology, and the interface, and find out all these headaches and kind of papers from India that what headache manifesting in children and then coming out to be a secondary cause due to this genetic.
So one question to you. I till now have got 3 cases of mitochondrial headaches. Sir, in adult population, how often do you see and follow up mitochondrial headaches who present only with migraine-like headaches?
They are usually in adolescent group only. I mean, not in typically adult group. I have not yet to see a full Milas or something like that in an adult, say 25, 30 years old. But I have seen quite a few in the age bracket of about 16, 17, something like that, or even pediatric also, because we also see pediatric headache patients. So I think that is less common, and also I think that the suspicion index, that should be very high. That is a way to move forward. Otherwise, you will miss out most of this diagnosis. By the way, how did you give the arginine infusion? I mean, it's available.
Arginine, no sir. We tried for the arginine infusion, which was like said that it will be available, but then we got the powder, which was given to rice tube. It is available on Amazon.
That's what. No, because I have been trying to get arginine infusion. It's very difficult to get.
But
Arginine
then
powder
we get
is
the
available.
rice tube through Amazon.
Yeah, that's what I was asking Ashish.
But again, sir, arginine, do you have any specific strain for headaches? Because we gave whatever is available on Amazon, the best thing we thought, but that is for the bodybuilders. It's not for the mitochondrial disease.
That's what you have said, no?
No, we are giving that, but it is associated with other things. Now, sometimes pure arginine is very difficult to get. It's associated with it's for the gene people.
Right.
So it was a difficult thing to. Yes, sir, it has worked. The child will last video is saying that Ami bhalo ache.
I just wanted to add one point regarding whether or not we can prevent this mitochondrial, whether we can diagnose it early. So what I have seen in some of these kids is that they will have some kind of short stature, they will have some ID, they will have some soft markers, which sometimes will help us to investigate them more. Yeah, so they will usually have these soft markers, like they will have short stature, they might have a family history of hearing loss or a severe headache or young strokes. So those, I think many times some kind of facial
But this
dysmorphism.
child did not
This
have
child definitely not have,
spontaneous
so we
mutation.
probably would not,
Yeah.
not guess, and but most of the times what we see is they usually have some soft markers. So in those ID is another thing which I see very common. I think those patients require further investigation.
Thank you everyone, and both the speakers and the panelists for this wonderful.